Thank you.
Well, good afternoon, good morning, good evening, wherever you are. You are here for the UPDWG, the UAV for Pedro Kremer Working Group webinar. I'm gonna give one minute for people to join, to let people join. I see somebody is trying to. So we will start in about 1 minute as people are trickling in. People are still coming in. 30 seconds, and let's get started. Well, let's get started. Hello, everyone. So my name is Olivier Lefau. I am the co-facilitator, co-coordinator of the UAV for Pedro Kremer Working Group. And today I will be facilitating an amazing webinar from the Zipline team, who will be talking about how vaccination rates in Ghana soared while the rest of the world backtracked during the pandemic. So the webinar will be divided in two parts. First, presentation about 30-35 minutes presentation by the Zipline team. And then we'll open the floor to a Q&A section. I would like to first, if you have questions, comments, there is two ways to contribute. If it's before the Q&A section of the webinar, you can enter your question by pressing the Q&A on your screen, and my colleague Gabo and I will be monitoring and will take notes of your question or your comments, and we can bring that back during the Q&A section of the webinar. Or if you want to contribute verbally, we will want to do that after the presentation. And for that, you will have to raise your hand, and then we will unmute you, and so you can ask question directly. So today we have three experts really on health impact, and I'm very fortunate how to measure health impact of innovative solution. I'm very fortunate to be in presence with and introduce Dr. Pedro Kremer, who is the head of the research and impact group at Zipline. Pedro is a physician, public health specialist, and epidemiologist. He has conducted health policy research for governmental, academic, and multilateral organizations such as WHO, with a focus on access to health inequities, and healthcare delivery network. And at Zipline, he routinely monitor the company's supply chain performance and its effect on range of outcome. He also collaborates with government, university, and other research institutions to measure and evaluate Zipline's impact on population health, the environment, and other areas of social benefits. Welcome, Pedro. We will have also Maria Jose Ospinada Fadul. Sorry if I'm not pronouncing that perfectly. She's a health economist at Zipline, and she has developed health and innovation policies in the Colombian government, advise governments in Latin America, in Europe, and on the public procurement of innovative technology, and serve as a health economist in the British government, where she was responsible for leading cost effectiveness analysis of public health policies on non-communicable communicable disease. And currently, so she leads the she's the lead economist at Zipline, developing value proposition for the perspective of social return on investment. Welcome, Maria. Last but not least, we have Florence Haruna, who is a M&E monitoring and evaluation research analyst at Zipline, where she leads research on the effectiveness of drone technology in improving access to blood, expanding vaccine equity, enhancing maternal and emergency care, and increase access to health products in Ghana. Her foundation is in medical research. His foundation in medical research began with a bachelor in medical laboratory technology, and then a master in health system research and management. So welcome, Florence. So as you can see, we have really high-stake subject matter expert. So we are extremely fortunate to have a little bit of the time to talk to us about the latest analysis, and very excited. Thank you, Pedro. Thank you, Maria, and thank you, Florence, for being with us and taking the time. The floor is yours.
Thank you, Olivier. Thank you so much, Olivier, Gabo, everyone in the working group. It's such a pleasure to be here again. We've been here, I think, over a year and a half ago, maybe a little more, presenting another study, another independent study. In that case, it is amazing to meet again. It's amazing also to see the progress that the entire working group is doing with relation to area logistics. So I will take probably just 5 or 6 minutes to introduce for some of us in the audience that maybe they are not fully or they're not very familiar with our work and our operations. I don't want to take a lot of time because the main plate here is the research that we want to present that Florence and Maria will present right after. So Zipline is, as you probably already also know, and as happens with other companies, you know, the drones are the main thing, the thing that comes to view immediately, and it's like, oh, this is a drone company. But we always want to make the kind of a clarification that even though the drone is the first thing or the thing that most of people will see flying on the skies, this is a much more complex operation that of course involves the drone. Zipline, I would say, success makes a lot of sense when you consider these 3 things that we have in the screen right now. On one side, the whole amount of warehousing and inventory management strategies and operations. We build the things we call nests. These are basically big warehouses where we store products in, maintaining obviously, temperature, humidity, and cold, and everything else that we need to keep those medical products, medical commodities, and some other commodities as well safe. From those places, we receive orders from number that it goes from just a handful to hundreds of what we call delivery points, or that usually these are health facilities. We deliver products from these distribution centers. The distribution center or the nest is built right by what could be called like the droner, right? So we receive the orders, we put the orders on our drones. The drones deliver within a range that is close to 100 kilometers. And because of the speed, those deliveries, the average is between 30 to 40 minutes. It always takes more than 60 minutes, less than 60 minutes, sorry, until we make that delivery. And then the last thing that usually goes unnoticed, but it's a very important thing, it's data and performance management as a product. In itself, we collect and analyze a huge amount of information that that follows each of the products that we receive at our distribution centers, what we deliver, when we deliver, how long it takes, and of course, what type of products we are delivering. So this is a fountain of information, of data that it's definitely used by us for our own planning and forecasting, but it's also used by our customers in a way to understand what is happening, right? What is happening in the field. In many cases, information coming up from very hard to reach, very remote facilities to the places where decisions are made takes a lot of time. And we really streamline that, that flow of information. We'll talk a little more about that at the end, I believe. I think we can move to the next one. So a few things I wanted to comment here, also in terms of the scale or the size of our operations. We have 13 operations centers or distribution centers across 5 countries in Africa. Our main customer is our customer, basically, is the government. We are a tool that the government uses to improve and increase the distribution of commodities to mostly hard to reach locations. We employ 100% local talent. You will not see anyone from San Francisco operating or flying or doing any kind of fulfillment at any of these distribution centers in Africa. And the last point I want to make before passing the floor to Florence is why this is not just a drone operation. This is actually for us, and the way we want to present this solution is it's actually a full transformation of the supply chain. As I'm sure many of you already know, supply chains in general operate in a kind of a push type of operation where someone at central levels, usually the federal levels or the state levels, and in some cases the district level, they plan for the facilities, right? And they say, okay, I think that this facility will need X amount of vaccines or X amount of any other products. And they deploy these big trucks that deliver usually 3 or 4 times in a year. And then what happens at the facility is it's a kind of unknown. In many cases, they don't have the right conditions to store. They don't have the right conditions to deliver or even prescribe. And there's a lot of wastage. Usually the system is very ineffective. There is a bunch of evidence showing that that system is ineffective when you compare to this other system that we are, that is basically the basis of our operation, which is switching from a push system to a pull system. That means we reduce the load, the size, and the amount of those big trucks that go to each of the very hard to reach locations. We centralize the commodities at our distribution centers, where we can be completely certain that we're keeping all the the cold chain and other environmental and structural needs for each of those products. We track and trace every single commodity that we receive from the moment where we receive it. We do quality check, and we know where each of those commodities is going. And then we receive an order. It takes about 5 minutes to pack. It takes another 5 minutes to put that order inside the drone. And it takes anywhere between 5 or 10 minutes to 60, like I was saying earlier, to deliver that product to a facility to be used right away. So it doesn't matter if the facility has a fridge or a freezer or temperature conditions to store, because they can place those orders on demand. And this is the basis of the pull system. They know that whenever they need a product, they receive it and they can use it. Wastages go down in an incredible way, and operations in general improve. And we really believe that with this, the other thing and the main thing that improves is access, basically trust in the health system and access to healthcare. So I won't speak any longer about this general, kind of presentation of Zipline. I will pass it to Flor. We'll be presenting the study that we just published and cost-effective evaluation that Maria will walk you through right after that. And then we will stay around for a Q&A. And that's all I have to say for now. We'll see you in a minute. Flo, it's all yours.
Okay, thank you, Pedro. So we are very happy about this research that we embarked on in collaboration with the Ghana Health Service team at the Western North region. So some background here that we've been delivering to this region since 2020. And as of the end of 2022, we had delivered 11.2 million doses of vaccines to the region, 3.1 million doses of vaccines to the region, and then 11.2 million doses to the country at large. And this particular study happened around the time that COVID-19 pandemic was actively in force, where there were restricted movements, there were fear among people, especially in seeking healthcare at the health facilities, because they feared they were going to contract the COVID-19. And the Western North region, we had already partnered with them to deliver vaccines solely to a number of their health facilities. I think the number is about 77% of the health facilities. And so we partnered with them. So this research was a collaborative one, which meant a lot to us because we did everything together, the protocol, the analysis, like especially in explaining some of the findings, we gathered a lot of context from them. And that actually helps to add credibility and validity to the findings that we had. So we used a combination of cross-sectional study design and retrospective quasi-experimental design, given that we wanted to estimate the impact of Zipline on access to vaccines. And analysis, we combined, we did a number of descriptive analysis and also a number of inferential statistics, notably the difference in difference analysis to establish causality of Zipline aerial, end-to-end aerial logistics on access to vaccines. And we considered three main objectives. The first one was around supply chain. So our hypothesis was that if there is access to vaccines, and then there would be like an improvement, you know. So we looked at the perception that the health workers had, and the health workers were across 156 facilities. The perception that they had in terms of their access to vaccines. And the second objective was like a build up from the first one, that if they have access or their supply chain was good, then they would be able to cover a number of children in terms of vaccination. And that informed the second objective around vaccination coverage for all the vaccines that we deliver at the Western North region. And then the third is also a build-up from the second one, that once the health workers are able to vaccinate children, then the children will be safe from the vaccine-preventable diseases. And so we sought to look at whether the vaccines actually prevented health outcomes related to the vaccines. Okay, so moving on to our findings, we've actually arranged our findings according to the objective. So this covers the very first objective around supply chain. So when you look at the chart on the left side, it's a chart about the frequently stocked out vaccines reported by the health workers. And you notice that the Zipline said facilities, which are the cases, actually reported lower stockouts compared to the control group. But there was some slight deviation with rotavirus, where we recorded a little higher stockouts compared to for the Zipline said facilities. And deeping dive, there were a number of factors that we attributed this to, that's like a shift in demand and supply, which also led to stockouts at Zipline. And so when you read our paper, you notice that we gave a recommendation on Zipline to look at its demand forecasts to ensure that these vaccines are always available, irrespective of the shifts in demand and supply. And then looking at like the duration of stockouts, the control groups recorded a higher stockout duration. And it was lower for the Zipline said facilities because outside the traditional means that they have with the control groups, they have like additional alternative source of vaccines, and that is the Zipline end-to-end area logistics. Then we also estimated the missed opportunities to vaccinate children. And here too, interestingly, we had the control facilities recording higher missed opportunities. And this is actually a finding that our very first presentation on this webinar some years back touched on for the independent study, which also recorded a higher missed opportunity for control group. And it means a lot. If children are missing vaccination, we all know the dire consequences that they have to face. And then we move further to inquire about their perception, the perception of the health workers on whether they think that access to vaccines had improved within the region. And we had 91.1% of them perceiving that there's been a considerable improvement in access to vaccines. We further estimated, like try to understand what factors influence the improved satisfaction that they recorded. And we noticed that for facilities that were served by Zipline, they were more likely to record or perceive that there was an improvement in the satisfaction. And we also look at factors that led to dissatisfaction, and the factors were frequent stockouts of vaccines and then missed opportunities to vaccinate children. And these are the reasons why they've been posted to the health facilities. And so obviously they will not be satisfied, they are not able to meet that. And this finding, the second objective around vaccination coverage. So here we use the difference in difference analysis. We ran the difference in difference analysis for all the vaccines that were involved. And from the chart you could see on the right, on the left side, the vertical line differentiates the pre-exposure to Zipline area logistics, and then the post-exposure. And in order for you to establish causality, you need to meet a parallel trend assumption. So when we ran the analysis, all the vaccines actually satisfy the parallel trend assumption, with the exception of a third dose of rotavirus and then meningococcal virus vaccine. And so meningococcal vaccine, sorry. So for all those that satisfy the parallel trend assumption, we further analyze them in terms of percentage increments. So here you could clearly see how the trend, they all satisfy the parallel trend, both cases and control. And then post the intervention, you see that there was a rise in Zipline, rise of vaccination coverage for the Zipline served facilities. And then the right side looked at the percentage point, which is like the further analysis I spoke about. And interestingly, we had a percentage point increments for all the vaccines ranging between 13.1 to 37.5. And it's very, very rare to record such percentage points for vaccine coverage. And also given the circumstances around like the COVID-19, we thought that most of the Zipline served facilities were more stable. They had more access to the vaccines compared to the control group, who were destabilized because of the many restrictions that were put in place and the fear for COVID-19. The third slide is about the health outcomes for vaccine. So here we also sought to understand, like I mentioned earlier, whether access to vaccines through the Zipline end-to-end area logistics improved health outcomes for the preventable diseases. And here we discovered that infectious diarrhea among 5 to 9 years old were reduced by 41.6%. We used the difference in difference analysis here, but it did not satisfy the parallel trend assumption. So we cannot say that it is what the reduction we see here is because of the Zipline area logistics, but we can only associate that to this reduction. And when we also took out like rotavirus vaccination, it didn't change. So we noticed that the association was independent of the rotavirus vaccination. And here we had, when you read our paper, we had a hypothesis around why this was so. These were the three main areas that we looked at. We associated it to increased access to essential products like ORS, nutritional products. And actually, these are products that Zipline also delivered, not all, but Zipline delivered some of them. And also increase the capacity of the health workers to promotes like preventive strategies like health promotion, health education, good counsel around like nutrition and all of that, and also increasing trust in the health care system. So when the communities have trust in the health care system, health facilities, that they would render them with quality products, then they are more likely to adhere to their counsel. They are more likely to go to them in order to catch like conditions before they go out of hand. And last of this, we estimated the number of deaths that were averted from the findings that we gathered, and we used back of the envelope estimation. So here we estimated that over 15,000 additional vaccinations that were done for children, there were over 720 deaths that were avoided. Yeah, so I would hand over to Maria from here, who would also delve more into like these numbers, especially around like the deaths that were avoided and then its economical impact. Thank you.
Thanks, Lawrence. I'm aware we're a bit tight on time, so I'm going to try to be fairly quick. So just a disclaimer, we wanted to give you some insights on the kind of cost effectiveness work that we're doing right now in the company, but these are very preliminary results, and we're hoping to submit this towards the end of the year for external validation. So we promise to keep you updated. I think it's important to say from the beginning that we have seen a shift. Like there's always been loads of interest in doing cost effectiveness analysis at Zipline, but we have seen a shift mainly because the amazing work that our monitoring and evaluation team has been doing has led to the publication of different papers that show the huge effect that Zipline has over health outcomes. And this has led us to see Zipline not only as a way of transforming the supply chain, as Pedro said at the beginning, but also as a public health intervention. And the natural tool for this kind of analysis, for analyzing health interventions, is cost effectiveness analysis. There's different advantages, and I'm here. I want to give a very, very quick overview of some basic concepts, and apologies for some people who I know this is going to be basic, but I'll try to keep it short. The advantages of cost effectiveness analysis are mainly that it's consistent with the fact that public health interventions are ultimately pursuing the improvement of health. So they're looking for the best value for money and not necessarily only for cost savings. And secondly, that it also allows for comparison between different health interventions that can pursue the same objective or different objectives, but they also end up being translated into, say, quality adjusted life years or other measures that are common. What is the main output of a cost effectiveness analysis? It's the incremental cost effectiveness ratio, and we call it ICERs. What these ratios are is basically how much more you pay for an additional unit of effectiveness with a specific intervention or policy. And this unit of effectiveness can be either a case of illness that is averted, another child that is vaccinated, and very popular in vaccine world analysis is the disability adjusted life years, or DALYs. And these ICERs are the one that tell us a lot about the cost effectiveness of a particular intervention. So if you see the graph on the right, and it's a bit counterintuitive, but higher ICERs actually mean that the intervention is less cost effective. And this makes sense if you think of it like if you pay $6,000, for instance, for intervention A to avert one DALY, that intervention is going to be less cost effective than you only had to pay $2,000, which is more close to intervention B. And there's also interventions that are not only cost effective, but also cost saving. This means that while the government is saving lives and averting DALYs, it's also saving money. So that's intervention C, where you save $1,200 per averted DALY. And there's a general convention that when you're talking about averted DALYs, if you are paying less than the country's GDP per capita, that intervention is considered cost effective. If you can move to the next slide. Thank you. So getting more into the weeds of the analysis that we're doing at Zipline based on this paper that Pedro and the team published, The objective was to study the ICERs of Zipline as a public health intervention in that same period of the GH4 study. And in terms of effectiveness, what we're looking at is the increase in immunization coverage that Florence presented, and we're leveraging that to estimate the averted cases of illness, the averted DALYs, and the lives that we saved. On the side of the costs, we're using the baseline costs from immunization economics, our costs, both operational and the amortization of capital, and the savings for the healthcare system. Parameters, just very general, we included all the vaccines for which we could find information on averted DALYs. These are 5. In terms of the target population, we kept it very close to the study. So it's the number of children that live in this districts that had high exposure to Zipline. This study perspective, we are only doing the healthcare perspective. This is important because we are not including, for instance, costs that the household have because they have to take care of a sick child. So in that sense, we're kind of underestimating our cost effectiveness. And finally, in terms of the time horizon, again, we're staying very close to the study that was published. So beginning of operations in GH4 until December of 2021. And the healthcare benefits we're looking at from the lifetime perspective, but discounting them at a rate of 3%. If you can move to the next one, please. So these are the kind of findings that we have. Like I said, I'm sure these numbers are going to change. We're going to give you a taste of what we're finding. So with a willingness to pay threshold, like I said before, this is usually equal to the GDP per capita, which in Ghana is around this value. Zipline is a very cost-effective intervention. For that period that we studied, we had an ICER of $23 per averted DALY. This was what the government was paying for each of the averted disability-adjusted life years for the population. We also found on the way different impacts in each of these boxes. If we can take the next one. So in the terms of the logistic costs at scale, and we have a slide later on scale, so we can go back to that later. Our average delivery cost per dose is up to 40% cheaper than the baseline. In terms of reduced burden of disease, we saw almost 1,500 averted cases of vaccine preventable illnesses. That is just for that group of vaccines that I mentioned. And this translates into almost $80,000 savings for the healthcare system. And finally, in terms of intangible and social benefits for those vaccines, we saved 23 lives and we averted 467 disability-adjusted life years. On the scale, this is something that generates a lot of interest from our partners. There are 3 things that drive cost effectiveness. One is the demonstrated impact of health outcomes. The other one is the healthcare savings. And finally is the delivery cost per dose. And what we did in this graph, and this is the kind of sensitivity analysis that we're doing, is we kept those 2 first variables fixed and we moved the delivery cost per dose. So we thought, okay, what if we had been operating the whole time at the delivery cost per dose that we were operating in the first 3 months? And then in that case, we would not have been a cost-effective intervention. Luckily, we overcame that milestone after only 3 months of operations. And after 3 months, we were operating at a price per dose, at a cost per dose that made us a cost-effective intervention. So that's the study period that we're looking at right now. But actually, after hitting the 2,700 monthly flights, we are actually now operating at a cost-saving scale. This is very important in terms of how we see cost effectiveness in general, but also how we see that scale is contributing to these results. And we go, please, the final slide. Another kind of analysis that we're doing with cost effectiveness is how do we compare it to other public health interventions? So what you see on this graph is the cost on average of getting another child vaccinated achieved through different health interventions. These are all interventions that we got from a systematic review that was published a couple of years ago. And as you can see, Zipline, those are the red dots that we have been able to calculate with this analysis. Zipline is much more cost effective than most of these interventions. There is, of course, difference if you're looking at the cost effectiveness of Zipline only for one vaccine or for the bundle of vaccines. For the whole bundle of the vaccines that I mentioned, there's a cost of under 30 cents per additionally vaccinated child, which of course is very low in comparison to what you see with other interventions, such as vaccination for all children, regardless of age, or monthly campaigns with mobile teams in villages and with incentives. And I think I'm gonna get back to Pedro. We have 2 minutes for the final remarks.
Yeah, thank you, Maria and Florence. I would time myself to take 2 minutes or less for the conclusions, and we have time. We're very excited for the Q&A. I guess there are basically 3 things we would like to say here as part of the conclusions. One is that the adoption curve really takes time. We were here, we were saying earlier, 2 years ago, and the study that we presented at that time was showing a pretty low uptake for what we even, the company was expecting. I probably you won't remember, but it was around 20 or 20-something%. That means the proportion of providers that were actually calling, Zipline to receive products, as opposed to calling, the regional medical stores or some other providers, that grew to 90% in this study in 2 years. 2 years is a lot, but it means that we need to be, these type of interventions, we believe they need to be consistent, and you need to work through a bunch of challenges, and it really takes time. But once it is established, once it reaches scale, that is the other thing I wanted to say here. I think it was clear from what Maria was saying. It really becomes cost effective, and it really can become cost saving as well. But of course, there is an amount of resources, human resources, and of course financial resources that are invested at first, and you need to go through that to have this platform up and running. Once you have it up and running, you can really get the best of it. We didn't mention it here, but we are actually delivering things that are beyond healthcare commodities in Ghana and Rwanda and Nigeria and other countries, because it becomes so cost effective. It becomes so convenient once you have this tool, this solution in place to use it, and the more you use it, the more scale you gain, the more effective it becomes. And the last thing I want to say is to really mark the importance of having a close collaboration, a close partnership with our customers, which are the governments, even if it's at the federal level or the state level or even the district level. The closer we get to work with them, the more aligned we are, the most effective we can become. It will be another research, but we really believe that it's not a coincidence that the Ghana 4 region, the Western North region in Ghana, is where we are having the closest kind of collaboration, and this is where we got the best results. So we are just a tool. We are just a solution. The governments can use this tool for good and for bad, maybe. But we are at their disposal, and we really try to provide input for those governments, for these governments to make the best use of it. If we don't have that, we are just a tool that these results would be completely different if we didn't have that close collaboration. And that's it. We are running research at each of those distribution centers that we mentioned at the beginning. We have over 8, or probably at this point more than 10 collaborations with universities. I can see some of them are in the call right here. So we will be back with more results to share with all of you. Thank you so much, and that's it. We'll pass it to you, Olivia.
Thank you, Pedro. Thank you, Maria. Thank you, Florence. What a great work that you have accomplished. Thank you so much for showing this. Thank you for the transparency and really showing your hard data. There's a lot of modeling exercise and assumptions. So this is really contribute to building the evidence of the benefits of the drone. Before I pass the floor for questions, you just said something that is really, 2 things that you said that's really important to me. And we need to keep in mind that transport by drone is just a tool. But it's a very important tool, when you start thinking, how can we address the equity gap of access of healthcare? And drone is really a very powerful tool to address this equity gap and to really make access to healthcare convenient to the community. Remember that it's to improve equity, it's about adapting to the needs of the community, to the preference to the community, right? And this is really, the data that you show really emphasize the fact that drone transport has real potential to improve equity, and thanks to its infrastructure hack that drone provide. And the second thing that you mentioned is really important, it's scale. And cost effectiveness is starting to show up at scale over time. So it's really important to set the expectation that it takes time to reach the level of the system being an equilibrium and reaching that cost effectiveness. You mentioned you started to be cost effectiveness after you were reaching 2,700 monthly flight. That's when the curve starting like really cost effective. How long was that? So I'm sure maybe I missed that. How long did it take from the beginning of the intervention until you reached 2,700 flights monthly and start becoming cost effective? Can you
Yeah, sure. I'm happy to chip in on that. So just a clarification that this is the specific case of our GH4 nest, but it was actually 1,600 monthly flights that were achieved after 3 months for us to become a cost-effective intervention. And after 2,700 flights, we became and we're now operating at a cost-saving intervention.
So that was 3 months, you said?
3 months for cost effectiveness and then a year for cost saving. Yeah.
Thank you. Opening the floor, please, if you want to ask questions, raise your hand and we will give you the floor. But I think there is a question from, I think a burning question from Gabo, I believe.
Yeah, thanks. A question for Maria. In your cost effectiveness analysis, your end-line costs, your intervention costs that you were comparing the baseline to, could you talk a little bit more about your thought process behind including both the cost of Zipline and subtracting the cost savings from averted illnesses and using that as your comparison?
Sure. So to be honest, we're trying to stay very close to the methodology that other papers use on cost effectiveness for health interventions, specifically for health interventions that aim at improving immunization coverage. What we include in the costs is, as like you said, our operational and the amortization of the capital for the delivery cost, but we also subtract the savings that the healthcare system is experimenting due to the averted illness of disease. And there's another very important part that we're assuming right now is, when do we completely replace the baseline delivery cost, right? Because there's a curve in which we contribute and coexist. And then at some point, and with some specific health facilities, we expect to completely replace that baseline cost. In this analysis, we have been very conservative, and we're assuming that we are coexisting with this baseline delivery cost, which I'm sure is not the case, and hopefully we'll be able to do some sensitivity analysis around that baseline delivery cost. Did I answer more or less your question?
Yes, yeah, you did. Thank you.
Yes.
Thank you, Maria. There is a question from somebody. I'm going to read it. It's in the Q&A. I'm going to read. is the Zipline drone payload volume capacity optimal for this kind of interventions? And have you done any analysis to understand if a drone with a different specification could have further increased cost effectiveness / saving?
I can probably take part of that. So the drone, there are many parameters that need to be maximized for the drone, for our aircraft to be efficient and effective. Payload is definitely one, how much we can carry, but also it's really important for us to see, because of what Olivier was saying in terms of our aim to reach those locations that are hardest to reach, that are most remote, we need to pay a lot of attention to the energy consumption and the distance that we can fly. So these are parameters that play in the same equation. And we actually are increasing the payload slightly by, for example, reducing the weight of the box or the packaging. And I guess that probably an important part of this response is, no, there is never an aircraft that will deliver everything that you can and want to deliver, because we have a limit. But what we managed to do, and it's actually working really well, is we can put 20, at this point it was 24, now it's 28. We can put 28 drones in the air at the same time. So it happens with certain products like blood or fluids that are really heavy, where we actually deploy 2 or 3 or 5 drones at the same time to reach the demand that we're being asked for. So I guess the answer has these 2 parts. So there's never an optimal, or there's never a payload that fulfills all our needs, and we are working around that with other theaters of this tool, which is, for example, the capacity to have many drones in the air at the same time.
Thank you, Pedro. I have a question it's actually from a colleague of mine, Susie Truong, who is a senior manager at Village Reach on the research and evaluation. And unfortunately, she was not able to join today. But her question was, Zipline has looked at cost effectiveness for vaccine, but Zipline transport many other products. Can you speak about why vaccine, and what do you expect in terms of cost effectiveness for other products?
I think maybe I can take the first and pass it to Maria, because Maria will have the most meaningful response here. But as part of the context, we really first needed to, to understand cost effectiveness, you need to first know your effectiveness, and then you can work on the cost side of it. And we are walking that path. There is, as you were saying at the beginning, Olivier, not much in terms of effectiveness, how many vaccines you can deliver, or how much, or to what extent you can improve vaccination coverage. So what we are doing is we are learning from the effectiveness side, for example, through this study, and then Maria is doing economic evaluations, departing from those effectiveness data points. It's like a sequence. I'll pass it to you, Maria, but I didn't want to miss saying this.
I think you responded perfectly well, Pedro. We are, like I said, and specifically in the slide, there are 3 things that we need to do cost effectiveness analysis: the healthcare savings, the cost per dose, and most importantly, the impact on health outcomes. So like Pedro said, we already have this amazing paper on vaccine, like the impact that we have over immunization coverage. So that's the missing piece that we needed to do this cost effectiveness analysis. But we have others on the pipeline because, like I said, there are some papers that have been published recently. There's another one, for instance, in postpartum hemorrhage. So I feel that as soon as we start getting more and more on our demonstrated impact on health outcomes, we're going to be very happy to start setting up these economic evaluations. I won't be able to say exactly from the beginning how each of these are gonna turn out, but we're very excited to start working in all of them.
Makes sense. Any other question? Please raise your hand.
Olivier, I think we have
Q&A.
some questions in the Q&A. Yeah.
There is one hand raised. Oh, it disappeared. Otherwise, the 2 questions we can combine from Cyril Sajou. Are these vaccines perishable? If so, what is the typical life of those vaccines? And what is the nature of the demand of vaccines at the health center? Is it random demand? Is it fixed demand? And so on. So those are two questions that is on the chat.
Okay. Okay. I mean, I think I can respond to this, and then my colleagues can add on. Yeah. So all the vaccines, or every vaccine, has expiration date as determined by the manufacturer. However, they all have like specific storage conditions that they are supposed to be kept in. For some of them, once it is open, it has like a limited time frame that it has to be utilized. Others, especially like ones that are stored in the freezer, some of them, once you open them and you store the remaining one in the refrigerator, you have to use them within some few hours, else you have to discard that. But one unique thing that Zipline is doing is that they are not keeping the facilities that we are serving so delivery. You don't need to store these vaccines, like they are with us, and then once the need comes, they request, and then they can have just what they need to immunize the children that are available, and helps to minimize wastage. Because once you open a vaccine meant for 10 children, and then you have just one child, after you use it, you don't have a storage condition, it means you have to discard that. So I think it's also one of the impact that Zipline is making at that front. And then I would also attempt the question around whether it's a random demand or it's a fixed demand. So for the health facilities within this particular region, they have a period within a month. I think that's the third or the first week of the month. I can't remember, but it's a week within a month where they have like vaccination, is immunization period. And so the demand comes, like they are able to estimate or know how many vaccines that they will need within that period. However, there are some few nuances where maybe due to movement or children being born, like the numbers will go up a bit, yes. But I would say that is more of fixed, but once there's also like a need, they can always reach out to us. So they are not restricted to receive the vaccines only when they have the immunization week. At any time at all, when a child is presented to them and they need vaccines they don't have, they can always reach out, and then they would have the vaccines delivered to them. Yeah.
Thank you, Florence. Another question from Marcus. Do you have any prediction of how much further you can push the cost effectiveness? And do you estimate a level where it flattens out?
Not right now, but I can definitely anticipate that there's a moment where the cost effectiveness flattens out, and that's just like the situation in any public health intervention. As you achieve economies of scale, there's a flat part of the curve, and it's something that we're definitely going to see with the sensitivity analysis. Yes.
Great. Any other questions? I have one, but I want to give the folks opportunity. Any other questions in the audience? Gabo, go ahead.
Thanks. A question for you, Florence. I was wondering if you could talk a little bit more about your hypothesis around the immunization coverage indicator, and specifically for the conditions of the COVID pandemic, where we know that coverage, one of the reasons why coverage dropped was really because less people were coming to health facilities to get immunized. And so could you talk a little bit about how your hypothesis of increasing access at the health facility could then link to increased coverage during the conditions that we know around COVID?
Okay, all right. So I would speak to that, and then probably Pedro or Maria could add on. Yeah, so we are all aware of the measures that were put in place during COVID, especially around movement. So it was in Ghana, for instance, it was a challenge moving from the health facilities to the regional capital to pick up the vaccines and back to their facilities. And then I think most of the fears too were around like the urban side, but most of the facilities we looked at were facilities that were more remote. And the health workers didn't have to travel all the way to the regional capital to pick up their vaccines. And so once they request, they have the vaccines delivered to them. And they were still able to have like their health promotion. That was the assumption, the context to that we gathered, that they were still able to run their vaccination because people were still bringing their children there. Because they are remote, I think it was very easy for them to bring their wards to get vaccinated because like the vaccines were available. That side was still smooth. And those were some of the like assumptions that we made around that. I don't know if I was able to respond to your question.
Yeah, that's really helpful. Thank you.
Great. We have only 5 minutes. Let's think about the impact of those results. My question is, how has the government utilized the results of your study for health program improvement, planning, budgeting? Are you involved? Can you talk about that? Are you involved in those? Are you influencing those discussions? Thanks using this data.
Yes. So the government is part of this research. In the list of authors, people who provide data, who work in the analysis. We have the regional director for the Western North region and some other people from her team. So yes, they are disseminating and communicating these results. And importantly, pointing to your question, Olivier, the government at the federal level, but also at each of the regions, because of how the country is organized, they develop their own SOPs in terms of how they will be allocating commodities to facilities. They develop their own guidelines. And Zipline takes part of those conversations when they develop their SOPs, and we proactively reach out to them to keep them updated on how the operations are going and what's happening, regardless of these kind of isolated impact studies. We keep them updated on what is happening from the data we see at our operations, the center or distribution centers. So to what point they actually adjust their policies and budgets, it really varies. It really varies region by region in the country. And in those cases where we have a closer relation at the local level, we can see our input being put in place and being used. In some other cases, not so much. It really varies.
Well, I count on you guys to really continue your advocacy effort and to change policy or to adapt policies based on on the evidence of the benefits of doing that, as you're showing. One question: what is the effect? What effect does weather have on the flight schedule? In other words, I mean, we know that you have a pretty high Zipline technology, have a pretty high IP rating. But what is your percentage of flight cancellation or flight delay due to weather increments?
Based on the places where we are flying, we are covering pretty much all sorts of weather conditions, including very, very high altitudes and extreme weather to both extremes, to heat and cold. We also have operations here in the US. We fly in snow conditions and in very, very humid and warm conditions as well. The only factor that can create a cancellation for us is wind. And it's not just wind, it's wind. It's a side wind and at a specific speed that I'm sure I will make a mistake if I say 25 or 30 miles per hour at this point. Florence, probably you will know better. But the rate of cancellations due to weather, it's extremely, extremely low. I'm sure I'm not making a mistake if I say less than 0.5%. Florence, I'll leave that to you if you have any comment on this one.
Thank you. I think Pedro, you hit the nail right on its head. Yes. So usually we have like allowable. I also allowable meters like side by side, where the drone, even with winds, once it moves away, it will still be able to, what the wind that will push it out of even that allowable space is what would cause like a possible cancellation.
Thank you, Florence. The last, is the result from the cost effectiveness published? Because I remember seeing your publication that showed the first part of your presentation. Are those published as well, cost effectiveness data?
No. I replied on the Q&A.
Oh.
We're hoping to submit something for external validation later this year. So we'll keep you updated whenever we manage to publish. Yeah.
Awesome. So we are the first one outside Zipline to see these results. So we are very, very fortunate and very lucky. Thank you so much, Pedro. Thank you, Maria. Thank you, Florence, for your time, and thank you everyone for joining this UPDWG webinar. The recording will be posted on our website at the latest tomorrow. Thank you so much, everyone. Great work. Let's keep learning about drone transport.
Thank
you so much.